So the other thing I wanted to highlight in terms of this introduction slide of the title is the collaboration that we as geriatricians do, not only in the area of clinical care with our physiotherapists and occupational therapists and social workers, but the collaboration we do as academic geriatricians here in the City of London with Lawson Research Institute, less so Robarts, because that is an institute aligned better with LHSC and more for basic scientists, but with the university, the two academic healthcare hospitals in the city. So it's always about teamwork, and that's what I'd like to emphasize. And so every talk I give, it's a disclosure of any conflicts of interest. So I have no relationships financially with pharmaceutical companies. I don't receive any money for giving this talk, and no, Roy Butler hasn't bribed me about all the nice things I'm going to say about St. Joseph's. I really do passionately believe them and the partnership I've had with them now for 25 years. The disclosure is, someone's turning my slide, is I'm going to talk about the big picture. And my other disclosure is some of my slides are too busy and have a lot of words on them, but don't worry, I'm going to talk you right through it. And here we go. So I'm going to start off with the big picture of and hopefully go quickly through some of the history of geriatrics here, where it was born in England and how it spread through the world, and then focus on the growth and the important programs and development at St. Joseph's and our relationship in our community. And then I'd like to focus more specifically on what is a geriatrician. The reason why I've added that is when I'm in clinic, I introduce myself and I say, I'm a geriatrician. And then the patient or the family member says, what's a geriatrician? And I say, well, it's the opposite of a pediatrician. And then they sort of get it. I'm not sure what screen you're seeing now, but my screen is gray. Should I pause, Matthew?
Oh, I'm sorry. I'm not sure what is happening there.
I see.
Are you able to control the slides?
All I see is a big gray blob in front of my slides.
Sorry about that.
Well,
are you able to advance it?
Oh, now this is looking better. Are you seeing, what are you seeing now?
You should be able to just use the arrow keys on your keyboard.
I think we're good. And so then we'll end up with more specifics of what a geriatrician does and how it can affect a person's life. I'm not advancing the screen right now. Maybe you can advance it. There we go. So geriatric medicine as a specialty, it's rather new. Internal medicine and surgery was long ago, probably in the 1800s, but geriatric medicine was born by a surgeon in England named Marjorie Warren, and every geriatrician knows this. And the phenomenon that she saw on the wards in the 20s and 30s and 40s and 50s in England was patients who were delirious, they couldn't dress themselves, they were confused, they were incontinent of urine, and they were unfit to go home. And so she began to look at this, and she initiated and refined treatment and used a multidisciplinary team of physiotherapists and occupational therapists and social workers. She identified who was treatable. She also initiated stroke rehabilitation to improve their quality of life and get them home. And then her work grew, and she was published in the British Medical Journal, which is a very prestigious journal, through 1943 and 46. And the impact was so strong that she began to have students, residents, fellows, colleagues, and geriatric centers grew throughout England and Scotland and Ireland, and then subsequently around the world. And I'm asking Matthew to advance to the next slide, because apparently I'm out of control. All right, and so There are many reasons why in North America, in particular, the growth of geriatric medicine as a subspecialty has been very slow. The initial geriatricians came from Ireland, Scotland, England, and they were viewed as imports. So that was another factor. The other factor is, even in today's culture, aging isn't sexy in North America. Part of the other issue is it was hard to grow the specialty and recruit new trainees into the field because the fee-for-service model to get paid is a challenge. Geriatricians tend to spend a lot of time communicating with people. So if it takes a general internist half an hour to do a consult, I'm required to do an hour and a half as part of my Ministry of Health billing codes. So the other part is that there's the system in training new geriatricians was limited. So at times in the growth of our division here in London, we only got the leftovers up to 1 or 2 training positions. And now we have 2 new training positions per year. And there's such a shortage of geriatricians. If we had enough applicants, it would be helpful to train as many as we can. So where geriatric medicine started in London, it was probably the second major site, the first being in Winnipeg, and Dr. Ron Cape is the father of geriatric medicine here in this city. He was professor, he began here in 1975, and that's where, when we look back at Parkwood Hospital, that was the old name and now called Parkwood Institute, this was the second geriatric treatment unit in Canada that was established here. And within a few years, in 1979, the Geriatric Day Hospital was started at Parkwood, and this Geriatric Day Hospital is still running today. Now, Parkwood Hospital was first at the Grand Ave location, and in 1985, with the Queen Mother, I think, officiating and blessing this building, it moved to the current site. And over the 1970s to 80s, there were many trainees. Some came from overseas, from Ireland, and Dr. Richard Crilly was a professor at that time who joined the faculty, and he stayed at Western beginning in 1982, and he just retired. So he is a contemporary of mine and my colleague until he retired in 2017, which just seems like a blink of an eye ago to me. The other important training that we have achieved here in London is internationally and world-renowned geriatricians like Dr. Chris Patterson, Dr. David Hogan, Dr. Graydon Manuli, and Lynn Beattie from UBC and other major centers who have geriatric training programs now at their universities. And another acknowledgement is Dr. Michael Borey, who is also a former chair and chief of geriatric medicine. He was one of the residents with Dr. Ron Cape. So this is about history and appreciating our legacy. And so he is still a faculty member. And we have another Irish immigrant, Dr. Joel Hurwitz, who started his career with St. Joseph's in Parkwood in 1988. He retired also in 2017, and his office moved to the St. Joseph Grosvenor site in 1990. And our division began to grow. In 1994, Dr. Chris Breimer started, and then within 3 months, I joined as a trainee. The other landmark in terms of the history is St. Joseph's assumed the government of Parkwood Hospital. Prior to that, it was the Women's Christian Association. And then I finished my training and joined as faculty in January of '97. And since that time, so I was the 5th geriatrician at that time. And subsequently, I'm going to motor through the next slide because it's a whole list of my current colleagues. And at the left, you'll see a picture of all of us except Dr. Montero Adasso. And we are indeed one happy family. Geriatricians, as well as rheumatologists, are rated as the happiest internal medicine specialists and happiest doctors overall. And sometimes I say, well, we can't cure some of the chronic diseases, but we can improve a person's quality of life. And that is really invaluable and very rewarding to me personally and to all of us who go into geriatrics. The other thing that you'll note by the asterisks is that we are training more and more physicians who are Canadian trained. And so that is another type of growth of geriatrics that helps support, in the big sense, the aging population. And then, so other just landmarks in terms of how collaboration with St. Joseph's has helped geriatrics grow and help serve the community of seniors. Programs were enhanced at St. Joseph's with Dr. Hurwitz having a clinic there. We started a regional geriatric outreach program in 1992 that was based at the Parkwood site, which provided home visits for many people in the outlying communities. I used to travel to Tilsonburg. We had persons, Dr. Hurwitz, who's photoed there. I'm in the background over here, but Dr. Hurwitz at his retirement party, he would drive to Goderich. So this is part of the reaching out legacy that St. Joseph's has. In 1994, Dr. Hurwitz was the director of the Geriatric Assessment Unit, where it was basically an acute care unit at the Grosvenor site at that time, which focused on the early stages of rehabilitation in a multidisciplinary team. Then reaching out to the London Health Sciences Centre, who was not embracing geriatric principles at this time, we gradually started a consult liaison team jointly with geriatric psychiatry to work on some of the other aspects of frailty and delirium for patients who have had surgeries. In 2005, the acute care of the elderly unit was established at LHSC. And then growing further, we have the continued work at St. Joseph's at the Parkwood Institute has been that original treatment unit started by Dr. Cape continues as the 30-bed unit for geriatric rehabilitation, where we see people who are frail, older, who have fallen and broken their hip, and we give holistic care to look at their cognition, their ability to perform their daily task. We have over a 70%. We take the frailest of the frail and could be, I think, 75 to 90%, varies on the month and the situation, will be discharged home instead of to long-term care. The day hospital is still flourishing, and I want to highlight the program called Physical Maintenance Program, which is based at Parkwood in our day hospital. And that shows that the innovation that the operational leadership of St. Joseph has in listening to patients' needs and listening to their employees who are on the front lines of care. The physical maintenance program was funded as a pilot by the Parkwood or by the St. Joseph's Foundation. And it was a physiotherapist concept to have people who are very socially isolated, who are at risk of going home and not doing their full exercise program, to come in once a week for socialization and for enhancement of their exercise to keep them more fit and less likely to return to hospital. So this program is flourishing and I think is so beneficial. The other benefit I've seen personally is my office is just down the hall, is that it gives an opportunity if the physiotherapy assistant or the physiotherapist who's supervising that program sees someone who isn't so well, they come and get me, and I've run down the hall to assess someone quickly. So it's really a great service. At St. Joseph's, we have a consultation service to support seniors and the healthcare problems of seniors, of the other patients in rehabilitation, as well as the veterans care units. We provide what we call the most responsible physician in the special care unit of veterans care, and that's the unit for people who have dementia and some of the behavioral problems that can be associated with having a diagnosis of dementia. Michael Borey leads that unit. And over the years, we've developed and been supported by our operational leadership to develop memory clinics, falls clinics, syncope, and that's passing out kind of clinics, a special type of falling. Osteoporosis is led at the Grosvenor site. We've had continence clinics, and we have general geriatric clinics. The outreach program that was started in 1992 is still flourishing. And a new program that the Ministry of Health, it was run first by the community care, well, what's called home care now. They changed their name with every government leadership. So it's called home care. Lynn, or CCAC, was running the Geriatric Resource Nurse Program. And that became part of the St. Joseph's leadership portfolio a few years ago. And with that, the care is now teamwork, where we do case conferencing with the patients that the geriatric resource nurses see. I want to highlight that also because it shows the connecting care and the leveraging of technology. The geriatric resource nurses have used virtual care in people with computers to continue their home visits during the pandemic. I can see if they can do a videotape, and then during the case conference, I can see how the person walks. And so then the case conference can decide whether the person needs to have recommendations from the team to go back to their family doctor or to see a geriatrician in clinic. Sometimes I make a recommendation that they need to be in the rehab unit, for example. And as all of our physicians in my division do, it's OTN, I didn't put the words down, but it's Ontario Telehealth Network. And we all do virtual consultations for family doctors who request them throughout the province. And moving on, with the help of St. Joseph's operational leadership, we've provided mentorship for new geriatricians and for program development of other facilities. And the ones that I've highlighted that started was the geriatric assessment program in Windsor, where I was a consultant there until I retired because they have enough geriatricians or more. So I retired there about 3 years ago, the November of 2020. So I worked there a little bit through the pandemic. And so we recruited various geriatricians to the Windsor site. One of our trainee graduates, Joanne Clark, is a lead geriatrician in Sudbury. We have Dr. Peel, who finished her training with us in 2018, is a regional geriatric leader in the Clinton Goderich. And we helped Sarnia Bluewater. We're still working on another recruit for Sarnia, but Dr. Amanda Giffen started in 2019 with Sarnia. So we really thank St. Joseph's for helping to facilitate the growth in the region. And the other way that our division reaches out is through a very special program. Dr. Linda Lee is a family doctor who has won the Order of Ontario for developing this MINT program, which stands, MINT, stands for Multi-Specialty Interdisciplinary Team. And the geriatricians here are part of booster days to help train family doctors on how best to do dementia care and dementia diagnoses. So we give ongoing support to our local family doctor teams who are part of the MINT network and provide consultations for dementia care. We helped, that's a funny pun for this slide. We established the HELP program at LHSC, and this is a research-proven program that's very simple, called Hospital Elder Life Program. It's been proven to reduce delirium, and delirium is a terrible side effect of acute confusion that's associated with a higher risk of mortality. The simple things that the HELP program implements is a volunteer or staff who help the patient get up and walk, to make sure that they're hydrated and have water that's reachable, and to provide orientation, to make sure the calendar and the date is correct and reorient them to where they are, making sure their hearing aids are in and their glasses are on so they can see and hear their environment. It's those simple things and not drugs that have such a big impact on patients in acute care. The other accomplishment we've had is finding ways to interest our medical students to become geriatricians. We've trained 23 new geriatricians. We've also supported other people who leave their practice for extra geriatric training called the fellowship. And we are innovative in research and education, falls, gait, osteoporosis, syncope, dementia, delirium, and quality improvement projects. Some of the quality improvements are working with hospital operational leaders about how to reduce falls, for example. And moving on, other important things we've done in order to improve the quality of care for older folks everywhere is to make sure that every medical student has exposure to geriatric education and curriculum. We do our best to provide excellent educational experiences for students and residents who choose to do rotations with us for elective training. And all family medicine residents rotate through our service, and that's 50 residents per year from family medicine that we at least give 1 month of training to. We've established a Banks Award for medical students who show promise in geriatric medicine. We help the Department of Family Medicine with their training for family doctors to do a 3rd-year care of the elderly for extra training. And we've created a certificate for the Royal College for extra training, like a fellowship in brain medicine. Other things, so we have to look for advocacy to help treat and provide treatment for seniors in other ways, such as informing our politicians and the Ministry of Health about the importance of what we do and the lives that we can improve and save and improve their quality of life. So negotiating with the Ministry of Health for an alternate payment plan and then renegotiating. We've established to improve patients' access to the latest in care. We've started a geriatric clinical trials. Well, actually, that was the first name, the Clinical Trials Research Group. And we have relationships with pharmaceutical companies that don't pay the geriatricians, but they might pay our research assistants to have access to some of the newer, almost on the market treatments for Alzheimer's disease. We look at gait and to reduce falls, for example. And nationally and internationally, the Canadian Consortium for Centers of Cognitive Clinical Research is another organization that collectively we helped start. And in terms of leveraging with Schulich and helping them understand the importance of geriatric medicine, because if we keep people who are senior out of hospital and out of nursing home, we're doing a service to all of healthcare. So we have advocated to increase the number of academic positions. From when I joined in 1997, there was 5 positions, and gradually through Michael Boré and myself, we now have 14 academic positions. And because there's a shortage of people interested in becoming geriatricians, we have 12 of those 14 filled now. And we're advertising. And so going forward, so what is a geriatrician? And what is geriatric medicine? We are a division of the Department of Medicine. So we are certified through 4 years of medical school, 3 years of internal medicine. So we're general internists, then we do 2 years of geriatric specialty training. And we're not gerontologists. Gerontologists are people who study the healthy aging and aging in cultures. What do we do? Well, there's a variety of things that an academic geriatrician can do. Some of us are clinical teachers, and we help provide lectures and or bedside teaching for the students, and do a lot of care. We can, others are researchers, scientists. They do less care in terms of ward work and clinic work. And there's a variety of types of clinical opportunities that we have, as mentioned, from the outreach team to the ACE unit to home visits and clinics. The type of conditions that we specialize in are multiple medical problems. So when a person has incontinence, they also fall. They have things like osteoarthritis or pinched nerves and other sorts of what we call neuropathic, that's a doctor jargon word, other sorts of pain. We have treatment, we have expertise in training in pain management, dementia care, prescribing and deprescribing, or appropriate prescribing. I've done 3 months of geriatric psychiatry training as part of my specialty training. Bone health. The other skills that we have to be certified in, as in our training program, is team communication, team dynamics, team building, communication, and of course those home visits as well. And in addition to all of that, we have to keep up to breath on all of the subspecialties of internal medicine so we can provide optimal advice about heart troubles and lung troubles and diabetes and that sort of thing. So the principle and philosophy, and this is my personal belief, but it is in general holistic and patient-centered. In terms of the things that are added value is understanding personhood, the individual patient's values, their culture, beliefs, their home and work life. What is their, and then we have to amalgamate and integrate that personhood and their wishes, desires, and what matters most to them with best evidence medical treatments and aging physiology and metabolism of medications. And I think the priority is a person's quality of life. People ask me, well, I don't want to live to be 100. It's like, no, I'm not here to try to get you to live longer. My job is to enhance your quality of life for whatever time you have left. And some people are afraid. My patients have said, coming to their clinic, they're shaking their boots. I couldn't sleep at all last night waiting for this appointment because I think you're going to put me in nursing home. And I have to say, no, my job is not to put you in nursing home. My job is to keep you out of nursing home. So we're going to move on and show you a case in a moment. And so part of that is looking at the holistic view, and that matches St. Joseph's mission and St. Joseph's values. And I note that respect, excellence, and compassion are the values that we chose for our division of geriatric medicine, and the one we added on was also collaboration and accountability. But mind, body, and spirit to me are the key. And there we go. And here is the similar, but said in different words. The Canadian Geriatric Society tells you folks what we do and as geriatricians, we prioritize what matters most to the patient, and we look at mind, mobility, medications, and that multi-complexity of psychiatric disorders, physical disorders, all sorts of illnesses. And what do I have to do a comprehensive? So the key word is, what is, so a cardiologist has a cardiac catheter to do their tool. I have a very heterogeneous assessment and treatment plan that's called a comprehensive geriatric assessment. It involves a full physical exam, neurological exam, looking at how someone walks. We have to do vision screens and hearing screens. We do a cognitive assessment, a psychiatric evaluation, a full medical history, and the expanded history of what makes that person interesting and where they live, their housing, their friends, what is their change in their ability to take care of themselves, their function, and looking at all of their hobbies, interests. And we have to have a collateral history with someone who knows them well. And a medication review is part of that also. So based on this, a geriatrician will make recommendations that are consistent with the patient's wishes. So that's all nice, but how do we know that that really works? And so I'm going to quickly go through some of that evidence, and hopefully no one will fall asleep. I see Matthew overall hasn't fallen asleep yet. And so the evidence of when a person gets a comprehensive geriatric assessment, they are less likely to go to nursing home. They're less likely to die. They're less likely to be readmitted to an acute care hospital. And they have improved function, better able to take care of themselves, their cognition improves, and their mood and spirit improves. So that was one study, and that was one of the first studies in 1984 in a very important journal, the New England Journal of Medicine. But the next slide is multiple randomized control trials. So that's where a person is given one treatment compared to the usual care. Now, a meta-analysis is one of the highest level of evidence that something works. It's analysis of all the trials done. So this was published in 1991, and It defines a comprehensive geriatric assessment as multidimensional and a diagnosis for frail elderly people with the purpose of planning, and the key is delivering medical, psychosocial, and rehabilitative care. And across the board, in whatever environment that the assessment was performed in, whether it's inpatient with follow-up, because just doing an inpatient geriatric consultation doesn't work. It's failed. No benefit unless the person has follow-up and implementation of the plan. And so it reduces mortality. And we've already know that it improves their quality of life. So then the last publication, by 2018, a comprehensive geriatric assessment is now the accepted gold standard for caring for frail elderly people in the hospital. And I would dare say, when they're discharged, perhaps prematurely from hospital, in these days and age, that happens, they still need care and support. Doing a comprehensive geriatric assessment from a home visit or in a rehab unit also is successful. So it's a process, and I've already alluded to the medical, social, functional needs, and it's coordinated care plan. So what's next? There's lots of research and different things that can be done to what are the limitations? Is someone ever too frail to benefit, perhaps? Is there a different setting that a person can have this complex treatment plan implemented? But we're going to do a case. So that's what's next, is to look at a case, which I hope is interesting and informative, because this would be a very typical case for our outreach team to manage, and for whichever physician is with the outreach team, it's to also manage. So Ms. Sadie Payne is 83 years old. She's a retired waitress. And you see her two friends here on the left. She lives alone with two cats and a dog, and you saw her other friend in the beginning of the slideshow. She was referred by the emergency room, and at LHSC we have, that were trained by us, geriatric emergency management nurses who starts the assessment and referrals to care needs. So that geriatric emergency management nurse will make the referral to home care, will make the referral to one of our clinics, for example, or to outreach. And so poor Miss Sadie Payne fell outside. She couldn't get up, and a neighbor called 911. And no relatives are nearby right now. No one around in town to help. So the story is, she was widowed 20 years ago, and she tells our GEM nurse, "I'm not going to any retirement home. I have a home. No, I don't need home care. I'm independent. I don't need it, and I don't like strangers in my home." Oh, so of course we have to take a very respectful approach. Well, when was the last time you were at the family doctor? I don't know. About 5 years ago. I don't need a family doctor. I'm fine. I cook, I eat, I'm independent. Oh yeah, I have some old arthritis, but what do you expect? I'm old. So there's a bit of fear of, you're going to put me in nursing home. And that's the sort of story she gave on the phone. And she agreed to the home visit. And what did we find? Oh, I'm trained to be very non-judgmental and support people and value their culture. However, there were some safety issues that put her at risk of harm living in this environment. So if we move on to the next slide. So in the first home visit, that was what was seen by the geriatric nurse and the social worker. And there were many safety issues. There's a fire risk, there's spoiled food where she might get sick, just falls. Her clothes were too loose. She had evidence of malnutrition, and there was evidence of a rodent infestation. Cognitive testing was done, and so was depressive screening. And so then they brought all of that information from that first home visit, which usually takes a couple of hours, back and case conference with the geriatrician to discuss a plan. And the plan was, this woman needs to see a geriatrician. And because of her beliefs and her lack of transportation, she wasn't going to come to a clinic. So the geriatrician went with a team member to do a home visit and to assess her. And along the way, whether it's the first social work visit or the many subsequent social work visits, is supportive counseling to assess her ability to understand her safety and to establish common ground that's consistent with her wishes. And some of the things that I will tell my patients is people who go through this type of assessment live in their own home longer. And I also will say things in my memory clinic, people who accept more help than they think they need do better and live in their own home longer. So I try to build trust. And eventually she accepted some home care, both nursing to look at medication compliance and for the new medications that the geriatrician prescribed, and a personal support worker. She accepted a home service, a cleaning service to help clean up the home, and continued social worker visits from our outreach team to help build trust. And it was very important for this lady who does have some dementia to establish a power of attorney. So in the next slide, there's going to be specifics of that. Well, actually, what's that? I think go back, Matthew. Yeah. Nope, I'm wrong. You're right. Go forward. A good geriatrician will always admit when they're wrong. So the physicians, after the physician's home visit, they had a second team discussion. And of course, the physician ordered lab works where there was some medical problems discovered with abnormalities in the lab. And the social worker got information from the neighbors, and they found a long distance niece. And I've had cases similar to this where the niece or nephew was in England, and they agreed to be a power of attorney, long distance, to support this person. So we connected with home care, there's other community services, public health because of the rodent infestation, and contacted the niece because probably in all likelihood there were some needs for some help with financial management. And in the next slide, we will see the continued need for the social worker to continue to build trust and remind her to advocate to all the other services to respect her wishes, to help arrange the services. And the other was the meal delivery services because she had malnutrition. And part of the strategy is to help her participate and offer choices. So it promotes her sense of autonomy. And she needed transportation service because the next slide is going to outline the specifics. So the part that was started initially and simultaneously by the rest of our outreach team, once there was floor space that she could walk on, would be to get her a gait aid and to look at the accessibility in her home in terms of, can she transfer into that bathtub? Is she safe? Even with the home care people helping for bath transfers. And then she had either some brain imaging. The treatment plan was she was treated for depression. She was treated for diabetes with a plan to help her be compliant with the medications. She had hypothyroidism and started on a thyroid pill. Her blood pressure was treated. She had treatment for cognition, which is usually non-pharmacological to start with. And she was also identified with the brain scan with a few small strokes. Re-engagement with her family doctor, and then a follow-up appointment with a geriatrician. She also went to our day hospital to have the dietitian, the social worker, and physio that was more intensive, and the nursing care when she was being titrated on her diabetic medication. So in the outcome, this was a work in progress for several months. So after 8 months of management, the outreach team and the outreach geriatrician closes the case file. So you can see that this is not a simple intervention that we do, like here, take a blood pressure pill. It's very intensive and supportive. She was then left with a plan of seeing her family doctor every 2 months. She had a geriatrician follow-up. She had daily home care. She then, when she graduated from our day hospital, she continued on as at the physical maintenance program. Her home is now free of trip hazards, free of rodents. Her litter boxes are clean and the odor is gone. She adapted to her new walker and she loves it. And oh yes, here's her picture. She's now smiling. She and her niece were reacquainted. Her power of attorney was established. She has fewer falls. There's been no more emergency room visits. She's happier. She has less pain because that was treated also. And doing things like getting dressed and walking around are much easier. So I have no idea how I'm doing for time. I don't see Michelle or Matthew frowning at me yet. But you have seen the process of the big process of how geriatric medicine and our philosophy developed from its birth, and how that philosophy is implemented for an individual in the diagnosis and treatment plan with someone who has complex medical conditions and who may be frail. And you've seen the comprehensive geriatric assessment in action with this case, and that is what's research and evidence-based. The other thing that you've seen, and I want to emphasize, that St. Joseph's is the home of geriatric medicine in London. We have a shared philosophy of mind, body, and spirit, and it's because of the collaboration with St. Joseph's and our like-mindedness that these important programs have continued to grow to support the frail elderly. And I didn't mention the word baby boomer demographics once so far, but that is the concern that we have, is the continued aging population. And we have St. Joseph's to thanks for the growth we've had.